Hello.
Oh, I'm so glad you're here. Today, I would like to introduce to you a very dear, close friend of mine. She is a family nurse practitioner, board certified, and also a psych mental health nurse practitioner, board certified. She has multiple clinics. I thought she had 5 or 6, but you have 11, and they're called Learning to Achieve Wellness. And I wanted to bring her here today just to kind of give you guys a foundation of what she treats, because I don't even know half the stuff that's out there and that you've educated me on. And I'm like, what is that? So tell me like a little bit about you. And then I want to share how we merged together in some of our stories because they're fun. Tell me all about you.
Yes. So, I started my nursing background, knew I was going to be in the medical career early. I started out as a CNA, and I started that when I was in middle school. And then I think you got to be a CNA like at sophomore or junior year.
Right.
And then got to leave in the afternoon and go to the nursing home and work.
Yes.
Instead of be at school.
I know. You got out in high school. My last year of high school, I was only there for 2 classes.
Yeah.
And then we would do like rotations in the hospital, like all the different places, right?
Yes. Right. And so you got to have some like responsibility. It was actually a lot of responsibility that early on. I started at the technical school. So I went and got my ADN first.
Okay.
2-year nursing.
That's your, yeah, right. We called it the AA. And that's what I did too. I actually first had a degree in psych. I went to USF and I was like, what am I going to do? But then I went back for the nursing aspect of it too. And I got the 2-year degree. So that's out there.
I did that. Right. And then I went into nursing. I kind of tried a little bit of different things. I went to the clinic, to the office.
Right.
And I learned a lot. I went to the hospital, of course, because you want to get your med surg background. And I did ortho there, and that was great. And then I landed at the state of Wisconsin, and it was at the state institution, which basically most of them have been shut down. This one still exists. It's for severely mentally ill and profoundly intellectually disabilitated. There's only, I think, 2 left in the United States.
Okay, so you did that right off the bat when you were young.
Yes.
So you were exposed.
I was like 8. No, I had to be 20.
Okay. So the funny thing is that we were kind of parallel. So I had gotten my psych degree, and when I was in nursing school, I worked for Tampa General Psychiatric Center.
Okay.
Which was on USF. And here I am, this little, 22-year-old driving people to ECT. At 5 a.m. in the morning. Scary that was? Yes. Yeah. And I would be taking these patients there, dropping them off and just waiting, and then having to take them back, and they would be kind of zonked out. And so, for like 3.5 years, I was in the mental health with like acute, geriatric. I worked for the juvenile justice department.
Oh my God.
With high-risk females and boot camp boys. So we both kind of, we wanted to do the nursing thing, but we hit the psych thing really early, right?
Yeah, most definitely.
How did that impact you think, being that young compared to now? Like, did it freak you out back then, or did you absorb it? Like, how did you embrace it?
I mean, I'm pretty much like a go-getter. I want to be able to do everything and do everything like 100%. So I actually like started there. Within, I think it's 6 months to a year, I moved up into like what they called a nurse clinician 3, so a leader. And then I became a unit manager, and then like on their administrative team, all within like, I think a year of time, which of course then urged me to go back for my bachelor's degree because I needed to have that to be able to be in administration.
So when I met you, because I knew Lily, let me tell you about a go-getter. We met at Tampa Family.
Yes.
And I went there because they were going to pay off part of my student loan. Right. Mm-hmm. I mean, that was the motivation.
Yes.
But for you guys to know, Tampa Family is for people that, it was like Obamacare. They didn't have insurance, and they never had anybody take care of them or anywhere to go to. They didn't have consistent healthcare, right?
Right.
Okay. So Lily and I met there and woo, that was like, that's the Harlem of Tampa where we were at that clinic, right? Right? What we saw. But to tell you how much of a go-getter Lily is, she, out of 80 providers, she was number one. Like seeing the patient to the point where they gave her her own clinic. And we were with physicians. We were with other PAs. There was like 4 nurse practitioners, 2 PAs, and 2 physicians or something, right? Definitely. Yeah, in this clinic. So, yeah, hats off to you because we learned a lot. Yes. So you went back for your bachelor's in nursing and then you transitioned into nurse practitioner. How long after having your RN?
So I knew like that I always want to be able to prescribe, diagnose, and treat. Right. So then I was like, okay, I'm doing it.
I love being here, by the way. Like I'm just looking at you going, oh my God, I love her. It just brings back memories just even talking about it.
I know. It feels like so long ago, but then it's just like yesterday too. Yeah. So I just wanted to be able to do everything I could ultimately do with my career and then also with my degree and my training. So I knew I wanted to go to a university that allowed me to be in person and have that
experience.
Yeah. So I chose Gonzaga University in Washington. So it was a lot of commuting because I'm from Madison, Wisconsin. So it was back and forth and clinicals and
did you have to arrange your own clinicals or did they do it for you?
Most stressful thing ever. I mean, it's so stressful when you know you've done all this education and then you're like, oh my gosh. So, I mean, I paid for a hotel somewhere and I would stay like way out in the boondocks and drive like 6 hours to get there. I worked in inner city Milwaukee for a lot of it.
I think a lot like our children or people that have seen us now so successful don't know the legwork that we have had to put into it, right? The sweat equity that went into where we are now and what we've developed. We both.
Yes.
I mean, you had your son, right? Yes. And early on, I had my kids and it was just like, okay, we're going to be these single parents and we're going to do this and it doesn't matter. So I know when it comes to relating with patients and talking with them, we didn't have a silver spoon, a gold spoon in our mouth, right? I mean, we felt it. Yeah. We did all the legwork. So then how did you end up in Tampa? Like you just decided?
So I knew I wanted to be someplace warmer. I also was looking for that loan repayment, which brought me to rural Georgia. Like, I mean, my son, the school there, if he would have stayed and gone to high school, it wasn't even a credentialed school. That's how small it was and how older it was. So it was a different style of living. We stayed there for a year. It was an amazing experience. I was at the urgent care by myself. And then I had my supervising that I could call if I had questions. And I grew that from like 2 or 3 people trickling into they made 12-hour shifts and hired like 3 other people. And we got a little billboard the outside that was like, electric ones. So that was exciting. And I know it was hard to leave, but I needed to give my son a better opportunity. And then they have the HRSA loan repayment in Tampa. So like you, I sought that out and that brought me to Tampa Family, which was really hard. I made good money as a nurse manager. I was in administration. It was fine, but I wasn't doing what I loved. It was like $40,000 pay cut to do what I wanted to do. I mean,
sure. Sometimes you have to go backwards to move forward. Yeah. People say, okay, 1 step back, 2 steps forward.
Yeah. So but it was just what I loved. Like you, that's what you love.
You go after your passion.
Yeah.
Right.
Exactly.
So understanding where you came from, now you're in Tampa, and then you and I met.
Yes.
We would consult with each other all the time.
Oh my gosh. We stood at the counter and it was like me and you and our supervising physician. Yes. And then we had like our other doctor that she was super busy all the time.
Yeah. There was PAs and everything else. We'd have heart attacks in our rooms. We would have prostitutes come in. This is hysterical, but even being in the Harlem of Tampa, I felt safe when I walked in my car because I felt like I knew everybody that was around there in the neighborhoods because they would come into our clinic. So we would have people that were incarcerated that would come in chains all the time, homeless people. Mm-hmm. I think my biggest story, like one of the stories I can remember is I had a homeless person in, she was coming in for a physical for something, I don't know. And, had to strip her down, and she took off her shoe, and a huge spider came out of her shoe alive, like a live spider.
I believe it.
Yeah. Right?
Yeah.
So, like I said, I'd have prostitutes coming every week because they would have gonorrhea and chlamydia. I'd be like, what are you doing? Right? Yeah. But then we would just have different cultures that were not exposed, didn't have the opportunity, didn't have insurance, and they would be diabetics. Their blood sugars wouldn't even register when you would bring them into the room.
Right.
And then we would have to send them out, or, their blood pressure's through the roof, same thing.
Yeah.
So I embraced that. That was a big learning experience for me. Right.
I think we were like given the opportunity to provide really good care to people that didn't have access to care otherwise. So it was being able to do that makes a huge difference because you're changing somebody's life by just being there for, our visits were quick. We didn't have a lot of time, but you knew that this might be like your one touch point with that person. So it was, are their immunizations up to date? Can I get a pap smear done at this visit? Can I make sure that, all their screenings are done? We had labs there. Let's get those done. You just tried to get everything done with that one touch point you could.
There was a lot of acute stuff too.
Oh yeah, for sure.
I can remember just a story of a guy coming in, and he didn't live around that area. And it was like a Friday night, right? And it was, and I was by myself. I had one other, and I had to tell him that he was positive for syphilis and HIV. And, so as a provider, the empathetic part of me grew.
Yeah.
Definitely. A ton working in that environment.
Yeah.
And then we moved together to a whole nother realm, which was really cool. Worked for United Healthcare.
Yep.
And we got the side of the inpatient. So we had to be the psychologist, the nephrologist, pulmonologist, the cardiologist. Am I right?
Yes.
It was nuts.
Yes. I remember you called me and you're like, hey, so... And then it was a very big process of interviewing.
Yeah.
And then we ended up over there together.
Yeah. And you excelled even there. But since then.
Yes.
It's been over 4 years for me, 5 years since I started my own practice. But I embrace every bit of this and love it. And I went one way, doing primary care, urgent care, and then, hormones and peptides. Yes, you went the psych way. So give me a little bit of what that story looked like for you and where you are now. And then I want to know about everything, like what you treat and everything. So
I think medically it drew me in first because I started with helping treat with medication assisted treatment. So that's treating for opiate use disorder, primarily some alcohol use disorder. So that kind of drew me into that aspect. And then I worked at a couple substance use treatment centers, providing their physicals, making sure they had their medication assisted treatment, and just noticing that also socially, psychiatrically, you have to have that grounding.
Yeah.
I think we noticed that a lot at Tampa Family too. It's like, I was kidding, but I'd be like, if I could only order this person a mom, that's what they need. So it was like, a lot of times you can't manage the medical components until you've satisfied the depression, anxiety. Maybe the person has too much anxiety to even go into the store and ask for their insulin, or if you're super depressed and they're like, oh, we don't have your meds, then how are you going to be able to work up the courage to call 5 times and ask for your meds?
Right.
And so there's that gap. It took a lot of work because I had to go back to school again. So it was another 2.5 years in school, clinical. I was blessed to have some really, really good preceptors. I got to work at nursing homes and training. I got to work outpatient. I got trained in substance use and also in the hospital. And it was great. I mean, I had to present my cases. I had to come with a plan for every single person. And I learned so much during that time.
Yeah. I know you have the specialty of treating depression, anxiety, like post-traumatic stress disorder, traumas. What, I don't want to say your favorite, but what do you feel that you're an expert in? Because I know you're a master of all of those at this point, but what's your specialty or what do you enjoy the most?
I mean, I love outpatient. It's great. I love that we're able to offer an array of services for depression that other times, you know, people can't get, like TMS and Spravato, which we'll talk more about.
Right.
But I love my psych hospital. So I go every single day. I get in the car, I drive an hour and a half, and I go up to round at one of the inpatient psych hospitals. And I mean, it's challenging. It's high acuity, but like,
is it acute? It's
Baker Acts. It's people that came in because their family exparted them. So it's dealing with when they come in, maybe acute psychosis, really differentiating what's the real diagnosis, cleaning up the medications, getting a long acting before they get out. Like, I mean, I love it.
Okay. I have a question because I know that people out there want to know these. Okay. So they have a family member that they feel needs to be Baker active, right? The person is an alcoholic, over drinking, or let's say too many drugs, right? And they're just like, this is not okay. Just to clarify and refresh me so I know, if they are a threat to themselves or to somebody else, then you can call and get them Baker active. Do you need to have one or two people say yes? And then do they need to be diagnosed by you or said yes? How does that work?
So there's 3 processes. One, Marchman Act. Marchman Act is going to deal with alcohol and drug use. It can be anyone that's the person that's dealing with the substance use.
Okay.
So a family member, friend, sometimes I've seen a social worker or something that knows the person do it. And you would go to the courthouse, you would get the paperwork, you'd fill out what is the concerning factor. That gets seen by a judge. The judge decides if it's pertinent.
Right.
And they would send an officer to the person's house to pick them up. They would bring them into receiving Baker facility where they're evaluated from psychiatric or psychiatric nurse practitioner within 24 hours and decide if they need to stay. So that's for substance.
What if it's though, like, Friday night? Midnight, and it's
so you don't have the time to do it. I think then calling 911, typically a police officer, hopefully a crisis trained police officer, because now when you're calling for a mental health issue, I know Hernando County has a crisis unit.
Okay.
I believe Hillsborough does too. So they send out people who are specially trained in Baker Acts and mental health. You can request that when you call in and you have a mental health event. Say it's a mental health crisis situation. Do you have a crisis officer?
Okay.
And
that's excellent to know.
Yeah, because there's different techniques. They may be able to escalate the event without having to result in a Baker Act. But that would be the best thing to do. You can call for a safety check too, or a wellness check, where maybe you're not with the person, they're not answering the phone anymore.
Okay.
And now you're concerned. Like the last thing they said was, I can't do this anymore. And now they're not picking up the phone. You call 911, you say, this is what happened. I need a wellness check, and they'll go check on that person.
Oh, excellent. That's good to know then.
Yeah.
So you're raising a red flag, but you're not deeming the person like incompetent or unsafe, but please just go check on them.
Yes.
And not to abuse that either, not because, I haven't heard from my boyfriend.
Yeah, that's probably not going to make him very happy.
Yeah, right? Or my child, because I'm a helicopter parent.
Yeah.
And they're not answering my text. Yeah. So you got to be mindful of that. Okay. That makes sense. Moving forward with the depression and anxiety, I know just from learning, we know that it has to be at least 2 weeks of someone being depressed, correct? And then for anxiety, 6 months, but that seems like a long time. 6 months of having horrible anxiety, you'll end up with ulcers and everything else. How do you navigate that? And what are the steps?
So I think being able to diagnose like adjustment disorder, so less than 3 months with anxiety or depression, depending on the severity, there's definitely interventions you can take. If it's mild, edging on moderate, a lot of times we're going to start with referral to therapy.
Okay.
What can you change in your life to be able to lifestyle modifications, maybe putting in a walk, deep breathing, meditation,
right,
yoga. I mean, things that are accessible at home, you know, because not everybody has
resources.
Yeah. So, I mean, usually, depending on your situation and environment, it's safe at some point in time to go out and take a walk or to sit in the corner and do some deep breathing and meditation.
I didn't even think about that. Yeah. Like with your environment, like where you're at, if you can get out and be wherever you go. But what about like the winter's going to be coming up and you can't get outside? Yeah. And that's my go-to. Like my go-to would be, okay, I got to go for a walk and get in the sun, the vitamin D. Mm-hmm. But people live in different states where it's snowing and it's dark and it's gloomy all the time. So it would just be getting out in something like bright or a gym or around people.
I think around other people is huge too. I mean, I know, you know, COVID, we saw the effects of that, definitely increasing depression, anxiety, even the after effects now, right? So people got used to that, maybe had a little underlying depression or anxiety, staying at home and isolating. And now all of a sudden you were asked to do that for 6 months, a year. And now you're asked to go back into society and it's hard.
Yeah, it freaks them out. It does. Mm-hmm. It does. I didn't even think of that. It's the opposite effect.
Yeah.
Of now traveling again. Yeah. Just having to go out to the store. People got so used to ordering their food online.
Oh, I know. It's so bad.
It is bad. Amazon packages. What are you doing now? What's in here? What's going on? Now it's just like an everyday thing. I get to go out too, but I'm going to order the Amazon package. And it's so easy.
It is. I think society, especially during that time, made it a little bit more feasible to be really depressed and isolative because that boomed around that time, I would say. I mean, we had Uber, but not as much, I don't think, for the delivery.
Did you find that you were more busy or you're more busy because of that? I mean, COVID for me, for my telehealth practice went crazy because of it. Mm-hmm. I think it just unleashed a whole nother realm, a whole nother stage of life, right? Yeah. You know, they say, the 60s, the 70s, the 80s, and well, how about COVID? Yes. Like COVID has its own era, you know, with everything. Sure. So, I mean, it's incredible, just that point. So, let's go back to depression,
anxiety. Yes. So first line, we definitely always want to encourage what can you do non-pharmacologically to be able to assist with changing the thought process. Because when we have anxiety or depression, it's stemming from most likely our prefrontal cortex. The neurons aren't firing as much there. They're starting to get kind of dormant. That's the area that's going to control our mood, our reaction to stress. Right. If you feel happy after something good happens, your interest, concentrations, everything's just kind of sitting there. And as we don't use that area of our brain as much, as it becomes sleepy or dormant, the neurons stop firing and you get more and more depressed. So if you can do something like cognitive behavioral therapy that stimulates those neurons again to wake up, be active, and think, you can start to regenerate some of that yourself.
So would that be doing activities?
Yeah, even activities, for sure.
What else would you suggest for the cognitive therapy? Is it conversation with people? Is it just because people are themselves just staying real dormant and not interacting?
I mean, physical interaction with others. So being able to be around other people, that's definitely going to kind of keep that area of the brain awake and happy and moving and get those good natural chemicals. Pets, that's another thing. It does increase dopamine, so that will help a little bit.
And you have to go outside to walk them, right?
That would be good.
And they will make you get out of bed because they'll get in your face. Right?
They get you up in the morning.
Your face, right? I know. Okay. No, that's great. I didn't think about that.
I think that's a good one. Being around other people, socializing, getting a physical activity that, you know, you enjoy, that it's something that, because if you enjoy it, then you're getting some feel-good chemicals like dopamine. You're probably getting like a little norepinephrine because you're triggering that like fight or flight, get up and move response, and then the serotonin is going to naturally increase with exercise.
So I just did a podcast with my life coach,
yes,
George Martinez.
I saw it.
Yes, and we were talking about rerouting, like physiologically rerouting your brain, your neurological pathways from even what you learned as a child, what you were exposed to, these habits, your beliefs in yourself, and kind of saying, okay, it's time to put that to bed and do a little something that scares you, but we have to reroute, because if not, you're going to go back to that same process of thinking.
Yeah.
So you have therapists at each one of your clinics, correct?
Yes, correct.
They all are licensed psych nurse practitioner providers or physicians?
Yeah, so we have like the psychiatric mental health nurse practitioners. Our specialty is training in medications and identifying and diagnosing, also providing information on like non-pharmacological options. But then we also have therapists. So they're going to be psychologists, licensed clinical social worker, or licensed mental health counselor. And their specialty is in lots of different things. So it's like so many different types of therapy that I didn't even know. Like there's art, that's anger resolution therapy.
Oh, there's like throw paint?
I know.
That's what I would think. Like throw
That's what I thought, like art therapy. Are we going to get a whole bunch of coloring and stuff?
Okay, yeah,
and then no, it's like anger resolution therapy. So they work to, I think, de-escalate those different events that are triggering. There's EMDR. We have 2 therapists in our group that do that. So that's rapid eye movement desensitization, and it helps with trauma.
Okay.
Yeah.
Let's go back to the art real quick.
Yes.
So, I know if you picture something and it scares you, it depresses you, you have to learn to take the color out of it. So I'm thinking the art like that. You take the color out of it, then you pixelate it, right? And then you kind of just like let it dissolve. So does that kind of go with it? Or is it still throwing paint? Like I'm trying
no, I think it has to do more with the restructuring of how you're thinking, like what you're saying. Yeah, definitely.
And then the eye, as far as the eye movement, is it a machine or?
So there is a device that can be used by telehealth now. So it could be at home, but otherwise, yes, it's a device in the office that they would use.
Okay. Wow. These are so cool. So when do you decide?
Licensed clinical social worker, licensed mental health therapist.
Okay.
Yep, they're trained specialty in that. So a lot of times they're trained in, I think, CBT, different mainstays of therapy, and then you can get additional certifications in different things. Like there's DBT. DBT is going to be dialectic behavioral therapy, and that's going to be specialized towards like people that have personality disorders. So those are really hard to treat because it's something that came from childhood trauma, how we decided to respond to different things. So there really isn't a great medicine for it. The medicine is therapy.
Okay. I'd say that again. Please say that again to me. So if this person, is it like a bipolar?
So it's a whole different class in the DSM, and it's going to be this whole little section about personality disorders.
Okay.
And there's different types. I mean, I think the one that we hear about most is borderline, and unfortunately it gets used as like a slang term almost, like that person's so borderline.
Right.
But it really has to do with they've developed ineffective coping mechanisms at an early age that has now went on with them, how they react. So you may be hyper reactive to something that isn't really necessarily directed towards you, or think that, you know, everybody's talking about you or something happened because of you. Lots of things are circling around that person.
So it's just rewiring their brain.
Narcissism is going to fall under personality disorder.
I was going to ask about that because that's huge on the internet.
Oh, for sure.
If the person's narcissistic or they're gaslighting, and I mean, I don't know if a narcissist would come to you and say, hey, I need help because I'm a narcissist, but do you do couples counseling, or do you have just individual counseling for a person?
So
or is it family?
Yeah, they do family, couples, and individual.
Oh, this is fantastic.
Yes, and all ages. So it is really challenging, I know, to have maybe a child that has behaviors, or maybe it's because of the situation that they're in, but some of our therapists are, you know, specialized in that, like 3 to 5 year old range.
So exciting. See, I didn't know. I didn't know that you've expanded, or that learning to achieve wellness actually had all this to offer.
Mm-hmm.
I've utilized your practice with some of my patients, just referring them, so on and so forth. But this is broad, and then it has its own like little segues and divisions. And so, wow, I'm going to need you to break it down with the chart so I could put it up so people could say, oh my gosh, they do offer. Like myself, I didn't know, then they're not going to be able to come to you and get the help they need, which is so important. Let's go to the med route.
Okay.
When do you decide, okay, a person, it will be most beneficial if I put them on something? And then what are the repercussions of that? How does that make them feel?
So there's instances where a medication might be required upon a first visit without prior treatment.
Okay.
So maybe there's a scoring system called the PMHNP. And if their score is scoring in the moderate or severe, it is indication to start both one of those non-pharmacological, but also start a medication at the same time.
Right.
And
we're all educated as providers. It's 2 questions.
Yeah.
Right?
The 2 questions. Yeah. PQH2, and then that will lead into the PQH9.
Okay. Thank you for clarifying that. Because with my patients, even they've been on some type of antidepressant, then I make them answer the PHQ2.
Yes.
Just to see where they're at.
That's so good.
Okay. And then
there's a 9 too. It's going to go through how you felt over the last 2 weeks, concentration, focus, moving slower, moving faster, feeling depressed, down, changes to sleep pattern. It really touches on basically like the 9 diagnostic criteria in the DSM and rates them. And then that lets us get a score to be able to decide.
And then the GA7 is for general anxiety disorder. Yes. And that's the 7 questions. And that's what I do with my patients too.
That's perfect.
There's not a 2 one for that though, right?
No.
There's just a 7.
They should have.
Which is, no, because I think that being a little bit more elaborate, like we'll kind of maybe hit areas where the 2 questions, they can bypass those more easy. Okay. I know it's situational. And according to your expert, the patient will come in and you'll be able to evaluate and then decide from there.
Right.
Correct.
First line. Usually we should be using first line therapy of SSRI. So that's going to be some of the very common medications that a lot of times you hear, right? Prozac or fluoxetine is the generic name, Zoloft or sertraline, Lexapro or Ciloprium. Those are pretty much our big SSRIs.
Side effects of those when people start them, and then how long do they take effect?
Yeah, that's the hard thing, is because we want to feel better right away. And these medications are building up the chemicals back in your brain that you're relapsing. So it's taking 6 to 8 weeks to give it an adequate trial, oftentimes at an adequate dose.
Yeah, it's a long time. Right.
And sometimes we say they don't work, but we haven't also given them a long enough trial first to see if they will work.
And do you incorporate therapy with them with that?
Yeah, that's a great combination.
Yes. Okay.
Definitely.
Because I always just my own with my patients say, listen, I can give you this medication. It's like with anything else, but if you're not going to move forward, mentally addressing certain things or even physically addressing it, it's not going to work. It puts a Band-Aid on.
Some people aren't ready to do that yet, right? Yeah. So they want the Band-Aid right now to start to feel better, maybe to get the energy to go to therapy and talk about it. And it's okay. I mean, you want to work with each person individually, but you're right. Ideally, it would be both together.
Okay.
Side effects are going to come with all medications. The most common side effects of an SSRI, I think, are sexual dysfunction, which of course is frustrating, decreased sex drive in women, or same with men. Also, weight gain is limited.
A lot of people are afraid of that.
Yeah. I mean, especially like Prozac is not really going to have weight gain associated with it. Some people say Lexapro and Zoloft, but the chances are very little. The other biggest one I would say would be like weird dreams, stomach ache.
What about if your depression gets worse?
Yeah, definitely. Black box warning on basically everything, right? If your depression worsens, or if you have suicidal ideation, I tell everybody you stop the medication and you call us immediately.
Do they decrease down or they just stop?
So usually it's happening right when they started it. So we will say stop and call us before you take another one, especially if there's suicidal ideation. But you're absolutely right. If you've been on this medication for a while, you've kind of gotten up to a dose where it's a treatable dose instead of a starting dose, it's essential to wean off. You don't want to just stop the medication. Your brain can go through withdrawals from just coming off of the medication abruptly, and then you feel sick.
Right. That makes sense.
Yeah.
Okay, these are great points. For anxiety, I'll get patients that before they have to give a presentation, they'll want to take propranolol or metoprolol, something. And I'm like, okay, but those are kind of with blood pressure too. So there's going to be other side effects that go along with it. And the cognitive therapy will help them opposed to just putting the Band-Aid on it. For depression and anxiety, which are the 2 level 1 drugs? It's Lexapro for anxiety, but I'm going to let you tell me and them because you're the expert. I don't, because I may say
so I have like my little range. So I say we can have the really activating antidepressants, which I tend to try to reserve for more on the depressed side. And then we have the middle, and then we have I'm super anxious with maybe a little bit of depression.
Okay.
So when I'm thinking super depressed, although Prozac or fluoxetine is FDA indicated for social anxiety, and depression, I typically think about that for my more on the depressed side person. It's real activating. We take it in the morning, gets us going, could decrease appetite a little bit. Then we've got kind of middle of the line, like Zoloft. Really shouldn't be super activating or super making you too tired. Should be able to be taken in the day. Some people respond more than others, so we have them take it at nighttime. And then you've got Lexapro. Lexapro is really going to focus on that anxiety, which in men can come out as aggression or irritability. That's one of the symptoms that doesn't present in women as much as men. So we need to, if we have someone that's very angry, is it anxiety?
Do you do like labs too? So hormones? Because I know women going through menopause, all over the place.
Yes.
Right? Or just even if it's a cyclic type of menstruation, when that happens, if they have PCOS or do you offer that, or would you refer them to someone like me? And because I'll do the base of labs and let me see what's going on too, because it can also be something physical going on that's causing the anxiety or the depression.
I agree completely. Yes. There are some things that we will screen for, and a lot of times maybe they've come in with those lab works, so to rule out like hypothyroidism. However, there's so many more things that can come up than that.
Right.
We're not, trained and specialized in hormones. That's a whole different thing that you are amazing at. And that's something whereas we're identifying that through like an interview as probable diagnostic cause, we would refer out, because again, we want everybody to get the best treatment possible, and managing hormones is
excellent. It's its own specialty. Yeah. I know just with your history, you'll definitely expand and probably get all the certifications and everything, because that's just what you do. You're fantastic. And then you have other treatments that you were telling me about, so I'll let you explain those. And I just want to get some insight. If they have failed with cognitive behavioral therapy, any type of behavioral therapy and meds, what's the next line?
Yeah. So if someone's tried cognitive behavioral therapy for a period of between 3 to 6 months and it hasn't worked, they've tried medications, often maybe in more classes than what we talked about. There's also SNRIs. Those are usually the next most used medications, like Wellbutrin. There's tricyclic antidepressants. Those are a little bit older, more sedating, like Elavil. So if they've tried 2 medications and also had CBT, typically that would cover for TMS or Spravato. So TMS is completely no medications, no side effects, nothing's going inside of the body.
It's not like ECT?
No.
Okay.
You're awake.
Because it was almost like
Everybody
I can see like their brain frying, you know, they would put the electrodes
because you're putting the person into a seizure, which ECT does have. It's still around today.
Electroconvulsive therapy,
yes.
if you guys are wondering what that stood for. Yeah.
And it has its spots. So if someone's suicidal long term, nothing has worked. You know, it can work if somebody is psychotic and needs additional treatment that the medications aren't working. So I have seen it work in situations that it needs to work.
Right.
So it is still there, but TMS completely different. So it's so exciting that I knew
transcranial magnetic
stimulation.
Yep. Okay.
And I knew I wanted to offer it. I offered it as soon as I first opened because I wanted to be able to treat my patients with the best care possible. So this is a treatment that will provide about 80 to 90% reduction in your in your PQH9 score by 50%.
After how many treatments?
After 36 treatments.
Okay.
So 7 weeks, less than a medication trial.
What does it look like? Like, what is it? How long does it take? Do you do it for? Do you do it every day? Do they come in every other day? How does that work?
Yep. So we use 2 different chairs. They're both the same kind of setup in that it's a coil. So it's like a little curved shaped device that sits right on top of the prefrontal cortex. We find the prefrontal cortex very carefully by measuring during a process called mapping. We determine the dose of the medication by doing some pulsations, some magnetic pulsations over where the motor area is the brain. We can get the fingers to move. So we know even if we get a little tiny finger movement, that's the dose that we need to be able to get to the prefrontal cortex, right? Because we don't do an MRI before everyone. We don't know exactly how deep that prefrontal cortex is, but we know the same amount of pulse that needs to get to the prefrontal cortex is the same amount that needs to get to the motor center. So we determine the dosage on the first day, which is mapping. And then you know, we treat here 36 treatments in a row. Optimally, somebody will come in Monday through Friday or Monday through Saturday and go right through their treatment.
How long does it take?
18 minutes. In and out. Come in on your lunch break.
So you have notes for them where you position everything and then how high to put the pulse, and they come in. What is the after effects? Like, because I know.
Yeah, you can go right back to work. You can drive. About 3% of people will have a slight headache afterwards. It's not like a migraine headache. It's more like,
like a pressure, like you wore a baseball cap a little too tight.
Yeah, like that kind of thing.
Okay.
Nothing's going inside, but you hear a tapping noise.
Okay.
It's like tap, 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 pause, tap, 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 pause.
Like an MRI almost.
Yeah, it sounds like that. I say don't do anything different. Everything will naturally improve. The only thing I do encourage is a little increased water intake. So it's kind of like we're doing physical therapy for the brain. Like we're asking the brain to work out for 18 minutes. Yeah. So the idea is blood flow is coming there. The chemicals are starting to get there and the neurons are waking up. So why does it take, 36 treatments? Because it takes a little while for those neurons to wake up and they're actually like reconnecting. So and that's what you have connections in the prefrontal cortex. If you're on medicines, it's actually working because the chemicals can get to the area of the brain that we want. Because you figure you take the medicine in, goes everywhere, right?
Right.
We only want it to get right here.
Right.
So when we use TMS, we're getting it right here. That's the only spot it's going.
That's fantastic.
So it's amazing. There's a trial called STARS-D trial, and STARS-D trial shows us what happens when we add additional antidepressants over time for people that don't respond well. Mm-hmm. So we know by the time we get to the third antidepressant, this person unfortunately has between about a 10% chance of getting better. Oh, so now we're at a third antidepressant and we're giving somebody an 80% chance of getting better. It's just so exciting.
Really?
That's why I was like, no, we have to have it absolutely at every single office. Everybody needs access. Why do we have 11 offices? Because I want everyone to be able to be a reasonable driving distance to be able to go get this treatment.
Are you only in Florida right now?
Only in Florida right now.
Only in Florida. Okay. Is anybody else licensed outside of Florida? Can they treat other patients that are not in the state of Florida?
We have a couple people licensed outside. So I have Rhode Island, and then we have a couple people that have New York licenses.
Okay.
I know that we're working on Georgia because we're heavily requested.
Oh, okay, good.
So,
Good.
But, it's a work in progress. I'd love to be in Illinois. I love the Midwest. Love to be in Illinois and Wisconsin if I could.
I know. I'm still working on New York. I have New Jersey, and that took almost a year to get that license. It's a lot. It's a lot to get licensed. So, unfortunately, at this time, patients that are in other states, can they even get therapy? They can't even prescribe anything like myself,
not with
right?
us, but we definitely will do our very best to go on. Like, I would recommend Psychology Today. I think it's the best referral source. We are happy to look with them. Okay. Also contact the insurance company as well, of course, to try to find somebody that's in work. We do make it our mission to treat everyone. So we are credentialed with every insurance. There are those off ones that if we need to, we'll get credentialed with.
Is there like a tier if they're cash pay too?
Yeah.
Like if they can't,
So
I was wondering that.
Because
I know.
Because I'm big on treating everyone.
I know.
So
I know. Especially with the it's almost somebody to me that is having an asthma attack. Like, how am I not going to treat you? Like, I have to treat you. I cannot not give you an inhaler or your meds or steroids. I'm like,
that's what I always say.
Yeah.
Like, how can I expect you to go get a job, get insurance, have money to pay for your treatment without mentally getting healthy? And then we're going to say, no, you can't have that.
Are you subsidized by the government? Will they give you anything?
We are not.
We need to be.
We're a for-profit clinic. But we do all this. I think with time, definitely, that's a vision, right? To be able to, right now we're serving everyone that comes in that way.
I know they probably can, like donations.
I think we are trying to figure that out for this coming holiday season or right afterwards, just kind of doing like a little bit of a get together where people that, we've supported or support us can come together and we can raise a little bit of money to scholarship people officially instead of kind of scholarshiping everyone through ourselves.
I'm so proud. I'm like, I love this. I love it. Because it's so needed. Yeah. It's so needed. Would love to dive into all the different disorders and stuff, but I know we're limited on time.
Spravato.
Yes, that's what I want to talk about. That's what I was going to ask you about.
It's so amazing. This. So it's an intranasal spray, okay?
Okay.
And you come into the office and do it. You do a couple sprays in each nostril.
You do it.
So we observe the patient doing it themselves.
Okay.
Vital signs are taken before.
What is it though?
So it's S-ketamine.
It is okay. So it's the same thing as ketamine?
It's a little bit different. So it's efficacy wise safer. It has long-term trials now up to 6 to 7 years out that say this is effective and safe for everyday use. Again, you're not having the same side effects of like sexual side effects or anything like that.
What about drowsiness, hallucinations?
Yes, it can happen during treatment. You can disassociate during treatment. Typically we see it at the beginning, like the first few treatments.
Okay.
And then after that, it kind of normalizes. Afterwards, you cannot drive for 24 until you've gotten a good night's sleep.
Okay.
So you have to have somebody drive you home. So you come in, you are observed taking the nose spray, your vital signs are monitored by a licensed professional. Those are documented. We report all of that to a safety monitoring agency called REMS. They look at all the data. If there is ever any kind of like drop in blood pressure or oxygen saturation, that's something that we would report to them right away and of course take care of our patient. We have never had that happen.
Do you
chill out in a recliner for 2 hours? You're just like, and we have little stands for a phone, or you can have the tablet, or you can have the TV.
So you do the nasal spray and then you have to sit back and relax
for 2 hours.
For 2 hours.
And then get a ride home.
So what is the difference in the pros? Because I have another provider. He will do the infusion, and that is 5 or 6 hours for, don't quote me on this.
So twice a week for the first month, once a week for month 2. Then it is every 2 weeks, every month, depending on what you and your provider decide.
Okay, so this is
like keep doing it. Just keep doing it. It's safe to keep doing. It's not intended to be stopped. What is the pro? It is covered by insurance. It's covered by Medicaid. It's covered by TRICARE. It's covered by Medicare. It's covered by commercials for depression.
For depression. Okay.
And now it's approved for monotherapy. So you could essentially come off of all your antidepressants and just take this. Can you imagine you're depressed, you've had to take a pill every day, and now all of a sudden you go to the office 2 times a month, you hang out for 2 hours, get a ride home, and your depression is good.
And there's no long-term effects, no hallucinations, no.
Even at a year and a half in, they're still noticing that people have improvements overall in their mood. So it's just like, it's amazing. So it's uptake in the glutamine, which they found is responsible for treating depression and also improving neuroplasticity. So when we were having TMS asked to wake up the brain, improve the neuroplasticity, so is glutamine. So that's what we're doing. We're making.
Would you do both of those?
Some people can do them both at the same time if insurance approves. I always say stack it. So if you can, do your TMS first. Let's get that neuroplasticity. Let's get that brain awake. Then let's get the glutamine in there and do Spravato, because that's your long-term thing. You can keep doing it. So you stack them and you feel great. You can live your life again. It's just so amazing. I mean, Spravato really, honestly, within 2 to 3 treatments, people see the change. So that's fun, right? All of a sudden you only had to do stuff for like a week and you're better.
What happens if someone goes 30 days without it? Like they go to Europe or they're on vacation or they just can't get to you or how about they're sick? Like what's the adverse events with that?
There's not going to be adverse events. They could notice the depression creeping back in. I would say longer than 4 weeks, because usually we say maintenance, try to get in once a month.
Okay.
Everybody metabolizes medications differently, so it could be a little bit different for each person.
Is there any side effects like headaches or cognitive, just confusion, or I know it wakes up the cognition.
I really just see it during the treatment, and that's why we have like people there monitoring, checking on you, like little candies to keep your mouth moist.
Right.
Yeah. Some people say it makes them feel like they're a little bit like intoxicated while they're treating.
Right.
But yeah, after a good night's sleep, then you feel actually normal.
Fine. Yeah. Pretty good. Oh, and insurance covers it.
Yes.
Okay.
Yes.
Okay. This was a plethora of information.
No, we could talk like all day.
And I love it. Yes. I'm so appreciative you came today, and I'm celebrating my own mental health wellness month. It's not across the United States or anything, but I just decided Carrera Telehealth and Wellness, let's do this. I wanted to bring you on. Wanted to get your insight and your expertise. I will post definitely all your information so you can reach to Lillian Ingram, and I love her so much. And I do. And she's credentialed all over the place. Just not with psych. She's a family nurse practitioner, so she can look over everything with all your medications and understands everything you're going through and really will evaluate you well. And then how many providers do you have?
I knew you were going to ask this question. So we have about 3 providers at each office, and then we have the 11 offices, and usually 30 therapists at each office.
That's so exciting. Do you have any animals? Like
we have one pet therapy dog.
I was going to ask that. Yeah.
She is a princess. She's like a fluffy Frenchie down in Sun City.
I might be able to get you a horse to come by once in a while.
Oh my God, that would be
something
awesome.
Really neat, right?
Well, we're going to be like our newest office that opened that made number 11 was Zephyr. So,
oh wow,
that would be a good place for the horse.
Right. Okay. Well, stuff to look forward to. Again, thank you for joining us. You guys, if you have any questions, you can put them in the comments. We have slides that I'll go through, present that next week on a live webinar. And I don't know, maybe if Lily's available, she'll jump on to answer questions too, just more specific. But appreciate it. Thank you. Talk to you soon.
Thank you, Danielle. You're so amazing.
I'm going to hug her.
Thank you for having me.
Thank you.